esteemed coach director and moderator and panel members, and also our speakers today. So, Dr. Ichapuria, he is our coach director, and we are very happy to have him as a coach director. He needs no introduction. He has been a pioneer in thrombolysis for stroke. He has published many articles, given many public lectures, workshops, etc. And he has worked as a public principal investigator for many, multinational stroke trials in the country, and he has been awarded with a esteem award by the Times of India Group Health Icon Award. So, welcome, sir, and thank you to have you here as a coach director. Next, we have is the very eminent doctor, neurologist in this field, and Dr. P. Vijaya, madam. And she also needs no introduction. She is instrumental as a president of Indian Stroke Association, and she is a member of key opinion leader in Asian Stroke Advisory Panel, past president of AP Neuroscientist Association, and her association with different stroke kind of membership is countless. And she has been, she has awarded with a many distinguished kind of recognitions award she has, and she is a pioneer of stroke care in Andhra Pradesh, and interventional stroke therapies in India, a gold winner from WSO public stroke campaigns, diamond status award from WSO angel
We'll move on. We'll move on. Thank you
Okay.
for the introduction.
Okay,
This
yeah.
is all okay, but let me say something that I am so happy to see Vijaya here. And she is the president of Indian Stroke Association, and it is a great honor for us to have her here on this platform as a moderator. And she's the most wonderful person, and has been a great stroke ambassador for our country. So
Thank you. Thank you,
really,
sir.
very happy, Vijaya, to have you. All this biodata is okay, but as a person, you are an amazing person, and we are so very happy to have you here.
Very
Thank
true,
you, sir. Thank you, sir. Hello, everyone. Good evening, everyone.
Good evening.
Everyone.
Yeah.
Thank you.
Okay. Kalpita, can we move to the next Dr. Nathiel? And he is, pursued his DM neurology from Tamil Nadu, and he is actively involved in clinical practice and academics, and he is associated with Wellness Hospital Meerut, and he has also his close association with the Medical College Meerut, as well as he has served as a postgraduate teacher and examiner in medicine at MUHS Nasik. So, welcome, sir. Very happy to have you here as a moderator. Then we will move to our next moderator, Dr. Prasanna Kasegaonkar, sir. And he is also a member of American Academy of Neurology, member of Indian Academy of Neurology, and member of several other academies. And he has 5 years of teaching experience, and in VM College, Medical College, and CSM General Hospital, Solapur. He is also recipient of many awards: Healthcare Professional of the Year 2017, then Dhanvantari Ratna Puraskar in 2018, and Aadhar Maharashtra Bhushan Puraskar in 2018. We welcome you, sir, as a moderator over here in KT Live. And then we will move to our speakers now. We have 3 very well-known neurologist over here as a speakers. Dr. Pramod Dhonde is the first one. Then we have Rashma Mohammed, and then Drishti Khatri. So let me first introduce Dr. Pramod Dhonde. He is presently associated with Dhonde Hospital and Shivansh Neuro Rehabilitation Center, Nanded, as a director, and he has published several, articles related to stroke treatment. He has presented multiple poster presentations, and he is a founder of Shivansh Neuro Rehabilitation Center, Nanded, which is an advanced multidisciplinary rehab setup. And he is an active environmentalist who is contributing actively towards environment. So welcome, sir, in KT Live. Then we will move to the our next speaker, who is Rashma Mohammed, and she is associated with SP Med Forte Hospital, Trivandrum, and she is a former assistant professor general medicine in Trivandrum. She has a recipient of prize for World Congress of Neurology, Montreal, France, and she also contributed in many research articles on stroke and epilepsy. So, welcome, madam, in KT Live. And finally, last but not the least, we have Dr. Drishti Khatri, and she is a consultant neurologist in Sai Shri Vita Life Hospital, Wakad, Pune, and she has MD Internal Medicine from BJ Medical College, Ahmedabad, with a fourth rank. She has completed MBBS from BJ Medical College, and she was a university topper, and she has worked as an assistant professor internal medicine in Symbiosis Medical College, Pune, and consultant physician with Naruvi Hospital, Vellore. And she has also published several research articles related to the stroke treatment and thrombolysis. So, welcome, Madam, in KT Live. And now I would like to hand over to Icha Puria sir to take it further. Thank you very much.
Thank you for the invitation and the kind words. And I must welcome Dr. Nathaniel Sase and Dr. Prasanna Kasegaonkar, who have been with us, I think, a number of times. And as usual, we learn a lot from all the presentations, and I welcome the presenters also. Pramod Dhonde is a very well-known neurologist from Nanded, and he has done exemplary work. And Rashma is from Trivandrum, and Drishti is from Pune also. So welcome to all of y'all. And let's start with the first case. Who is going first? Pramod, are you? Who's going first?
Me, sir, me. Yeah. I will go first.
Yeah, Pramod.
Am I audible?
Yes. Yeah. Little louder if you could.
So I will share my screen. My slides are visible? My slides are visible? Hello?
Yes, yes.
Yes.
Yes, please go ahead.
So there are these, one of the case in last one of the KTs I have presented is the extension of that thing only, that case which has been there. There are another two cases which I have done, that what we are calling is that it has an expanding horizon of IVT in stroke. So let us begin with the case. So this is the case of a 45-year-old female. She will present non-diabetic hypertensive with right hemiplegia with hemineglect.
Pramod, little louder.
Hemineglect with global aphasia presented at 6 hours of onset with NIHs of around 18 at around 3 p.m. in the OPD. Her vitals were stable. Pulse rate was 76 per minute regular. BP was 150/90. There was no cardiovascular any murmur or something like that. No atrial fibrillation was there. Carotids were normal with no bruit. Patient came in OPD with already done MRI brain with angio. So it is a 6 hours onset of stroke with right hemiplegia with NIHs of around 18. So this is her MRI. MRI was showing pre-thrombolysis MRI with both flare and diffusion showing watershed infarct on the left side. If you see the MRI, on the left side, there is patchy areas of involvement on the left occipital region as well as in the frontal and temporal region. So, and it is the corresponding with the, also the changes are seen on the flare also. Despite that, there was no flare diffusion mismatch and patient was presenting with the 6 hours. She was, again, I will show the images. There was left M1 thrombosis with some collaterals were there. In view of patient's deficit and age was concerned, as she was 45, she was doing excellent, everything was fine in her life before the stroke. It was better to consider clinical diffusion mismatch appropriate in this case, as we have done in the last one of the cases. And patient was thrombolized with tenecteplase with dose of 0.25 milligram per kg. And next day, her motor recovery was grade 2/3 in the lower limb and upper limb with speech deficit of aphasia. There was not much improvement in the aphasia part, but there was some motor recovery. So this was on the next day actually. This was the day 2 CT brain and day 3 MRI brain with angio shown. So this was the day 2. There was some corresponding areas of this Wernicke's areas were affected, and day 2 CT brain was showing infarct size increase as compared to the previous pre-thrombolysis MRI. And this was the day 3 MRI brain angio showing recanalization in the M1 with some collaterals were shown in the on the left side. So there was some recanalization that has happened with the thrombolysis. So this was the day 3 MRI brain showing infarcts in the M1 territory. So this patient was thrombolized in view of patient's age, and though there was 6 hours of onset of the stroke and patient was having significant deficit, the clinical diffusion mismatch was considered and she was treated with the thrombolysis part. And now she is currently at our rehab center and she significantly regained in the motor power. There was some speech deficit still there, but she has been able to walk, means she is able to stand without support at present, and upper limb movements were around grade 2, grade 3. So this was around 15 days now, 15 days of the illness. She is still in the rehab center now. So the concept of why we have thrombolized this case was this diffusion flare mismatch concept. It was identified, it was a multi-center observation study. This was in concept established in 2011. What it was showing is that diffusion flare mismatch identified patients in within 4.5 hours symptom onset with 62% sensitivity, 78% specificity, and 83% positive predictive value, and 54% negative predictive value. So many of the patients are missed out because of this diffusion weighted image and flare mismatch concept. So there needs to be some robust concept beyond this, because there are many patients which are this we can thrombolize, which we can consider definitely, and which should be thrombolized because there are considerable salvageable tissue, though there is diffusion flare mismatch concept is established. So this was the what is this diffusion flare mismatch? Clinical diffusion mismatch is that this was the acute stroke patients with NIHS score of 8 or 8 more or equal to 8 and diffusion weighted volume of less than or equal to 25 have a higher probability of infarct growth and early neurological deterioration. So the new concept of clinical diffusion mismatch may identify patients with tissue at risk of infarction for thrombolytic or neuroprotective drugs. Then this reliability of clinical diffusion mismatch approach to predict patients with these patients of potential for thrombolytic, that this approach of comparing clinical diffusion mismatch and percentage of infarct growth proved that concept of clinical diffusion mismatch can accurately indicate the existence of large volume of tissue at risk of infarction, that is penumbra. This is one of the trial which is not relevant to the case, but this is a recently published trial which has been published in JAMA Neurology in Feb. Recently, this was an option RCT trial, that is called option randomized clinical trial. The patients were almost 546 patients were there, and what this trial has done is that the tenecteplase was used for non-large vessel occlusion within 4.5 to 24 hours after ischemic stroke, and based on the penumbra, that is a perfusion weighted imaging rather than this clinical diffusion mismatch. Why I'm quoting this trial? Because we are expanding the horizon of the stroke, this thrombolysis patient. So this trial has added benefit of this salvageability in the non-large vessel occlusion. So why option? Clinical question. In these patients, what they have done, extended window thrombolysis supported by perfusion based selection. Existing data primarily focus on large vessel occlusion and mixed populations. And this hypothesis was that IV tenecteplase improves functional outcomes versus standard medical therapy in perfusion selected patients of non-LVO category. So in patients with non-LVO ischemic stroke, salvageable tissue on perfusion imaging and 4.5 to 24 from last non-well, does IV tenecteplase improve outcomes versus standard medical therapy? This was the question asked in this trial. So results were that primary outcome was excellent functional outcome at 90 days, 43.6% versus 34.2 with the standard medical therapy. And the risk ratio was around 1.28. So number needed to treat was 11. Absolute risk difference was 9.5%. That is very significant. Ordinal shift benefit was 1.39. Reperfusion rate was 37.7% versus 28.8 in the control group. And safety profile, 2.8% symptomatic ICH, tenecteplase arm, 0% in control arm, 5% 90-day mortality tenecteplase, 3.2% control. That is not very significant. So interpretation and clinical impact of this trial is that key finding is that perfusion selected non-LVO patients benefit from tenecteplase up to 24 hours with NNT of 11 for excellent outcomes, clinically meaningful. Supports tissue window or time window, which we have done in these patients, previous patient. Approach in clinically appropriated selected patients, extending thrombolysis eligibility. Comprehensive evidence extends late window thrombolysis data from TRACE-3 and HOPE trial, previous trials were there. So the important context and caveats are that Chinese only population, ethnic diversity limitations were there, open label design introduces potential bias, patients had mild strokes, SISH risk increased but absolute rate below 2.8%, and no multiplex comparison arm. So bottom line is that option provides class 1 evidence supporting tenecteplase using perfusion selected non-LVO stroke up to 24 hours. While hemorrhage risk increases slightly, the benefit appears to outweigh harm in appropriately selected patients. So this was the option RCT trial. There is another case which I will show in a short period of time. This is the 22-year-old female with no prior.
Pramod, let us discuss this case first. See, there are two other speakers. So I think let's take only one case.
Okay.
Now, in this particular case, patient presented in how much time?
6 hours.
6 hours.
Yeah.
So why did you bring up that thing that within 4.5 hours you should do diffusion, perfusion, this thing? Actually, it's not necessary to do.
No, sir. Actually, the patient came already with the MRI.
No, not in this patient. You showed one study which. Well, why do you need to do DWI this thing mismatch? Within 4.5 hours, you don't need to do anything. Vijay, what do you say?
Yes, sir. I explicitly instruct our students, if it is especially non-LVO, clinically, 100% only CT scan. After thrombolysis, you can do the angio.
Exactly.
So first, don't delay the IV thrombolysis. Just a simple plain CT, check your BP, check your sugar, give TNK.
Exactly.
But this was for 4.5.
So in 4.5 hours, you don't need to do advanced imaging.
That is, even the latest guidelines explicitly mention that. The 2026 guidelines say within 4.5 hours, you should not do advanced imaging. Just a CT scan is enough for thrombolysis. We all agree on that, of course.
Yes.
And now the extended period. You tell, sir, whatever you.
But Pramod, one thing, here the whole ICA is occluded, no?
Yes, sir.
In your case?
Yes, sir. Left ICA.
Yeah. So, no, what is important is that ICA was occluded and M1 was also occluded. And yes, after the TNK, M1 opened up, probably from the other side, we don't know. But it is very important because, many times we have seen that LVOs also open up with early TNK. This is a point I think, I mean, the interventionalists don't like it when we say it and they always fight with us. But I'm sure Vijay also, you have seen many times.
Yeah. We always
that
do it. The
these
trace
LBOs also open up with TNK.
Yes, they do. And also the trace 3 trial in China, the same thing. They have
Yeah.
the trace 3 trial where they do thrombolysis in LBO in extended window period when they don't have access to thrombectomy. And it was a positive trial, actually.
Yeah.
Actually, this another patient, what I was saying, this was a 22-year female. And
No, Pramod, wait. We are not able to take many patients.
Yes, sir.
How many patients do you have?
I am not showing this case actually, but I'm just telling the story. This was presented with GCS of almost 3, this patient, without any risk factor. And she was thrombolized at 5 years. And she has basilar artery was completely opened up. She has only mild cortical blindness, actually, that was the deficit. Otherwise, we thought that she would lose her at the time of onset. So this was the case where 5 years tendectic place has shown excellent result in this case also.
And the most important concept, I think, Dr. Chapuria, we know over the years of experience, the clinical CT mismatch is
Correct.
always worth trying for. If the NIHS score is high and CT is not bad, you can jump. You can take the risk with IV thrombolysis.
Diffusion flare mismatch is little bit overhyped thing actually.
Yes. So, you should do this diffusion flare mismatch after 4.5 hours or unknown onset or sleep onset.
Yes.
See, unfortunately, we are finding that everyone is just talking of diffusion flare mismatch. There is no need for it in first 4.5 hours. You're just wasting time. You just need a CT scan, and CT scan can be done in 2.5 minutes flat. Whereas MRI will take you at least 10 to 15 minutes and you will waste that much time, and therefore your door to needle time will go up. So what we are trying to emphasize is that in early time window, act fast, give the drug within 30 minutes. Previously it was 1 hour. Now we want to give it in 30 minutes. So how do we give it in 30 minutes? First, you have to have your entire stroke protocol proper. You have to have your hospital choreography ekdam proper. And you have to do CT scan fast and just give the drug in the CT scan. You don't have to shift the patient here and there. Absolutely. And another very, very important thing which we should emphasize is pre-notification. If you pre-notify, the CT scan is empty, the emergency room is empty, and you save clearly 5 to 7 minutes. So 5 to 7 minutes, you are saving about 10 ml of brain tissue. So this is what we are emphasizing. And of course, when it is 4.5 hours and beyond, then yes, you have to do advanced imaging, because otherwise you won't know. No? So, so this point I think is very important. Dr. Sase, do you have to say something?
Sir, we do agree, but only thing is that the door to needle time is lost only because of the consent of the relatives, without which proceeding further becomes very difficult. Otherwise, everything is ready, but the consent.
So everything has to work in parallel. When the patient comes into casualty, you start talking to the family.
Yes.
It doesn't have to be done serially. You'll see the scan, then you will take the consent. Everything has to be done together. So you need a team. Somebody is talking to the patient. Somebody is taking the patient to the CT scan. The nurse is getting the TNK ready.
Correct.
So if you do that choreography properly and you take consent, yes, consent is a problem. Sometimes family is not there. Sometimes relatives are not able to decide. And I find most important is some GP is involved or some physician is involved. He will create problem. So we are encouraging patients to come directly to the hospital, bypassing non-stroke hospitals and non-neuro physicians. Prasanna, what is your experience? Prasanna, where are you? Prasanna. Okay, he's not there. Vijay, what is your
opinion? With due respect, I agree. And
with due respect, yeah.
So it's always, what they do is, most importantly, they send for MRI first. The
Yeah.
patient goes out for MRI, comes
Go
back
far away.
1 hour. When there is no in-house thing, that's the most important. That's the delay.
Now, even Pramod's patient came with the MRI.
Yeah.
He came with the MRI.
He must have gone there within 4.5 hours, I'm sure.
So that's why it took 6 hours, no?
Yes.
So as public awareness, we must say to people that Baba, come to stroke hospital straight. Don't go here and there for MRI and this and get GP involved. And, unfortunately, it is a fact. I mean, we are facing it every day. Patients are coming in at 6 hours. See, if that MRI was not done, easily we could have saved 1 hour.
True.
Easily we could have saved 1 hour.
And then the other scenario is the CT scan will be normal and the doctor will say, no worries, the CT scan is normal. You go home.
So the commonest CT scan finding in acute stroke is a normal scan.
That's these
50% of acute stroke will have a normal CT scan. And sometimes even a normal MRI. Don't think that, sometimes MRI takes 3 hours. Diffusion picture to come takes about 3 hours. So sometimes even MRI diffusion may be. So it is clinical. What is the indication for TNK? Clinical diagnosis of stroke, not radiological diagnosis of stroke.
Right.
Everyone is looking at radiological diagnosis of stroke. What is the indication? Clinical diagnosis of stroke with CT scan not showing hemorrhage. That is the indication for IV thrombolysis. Clinical diagnosis of stroke. Okay, there can be stroke mimics. Sometimes out of 100, you will get some 2-3 stroke mimics. It's okay, yeah. It's okay. No problem. But it should be a clinical diagnosis of stroke. Okay, so Pramod, now you start doing public awareness. Come directly to my hospital. Don't go here and there and waste time.
Last 2 days, we have thrombolized. Last 2 days, we have thrombolized 4 patients.
Wonderful.
Very good.
So, we are so happy that people are doing everywhere, and this forum has, democratized stroke thrombolysis. It is not the purview of neurologists. Of course, Pramod, you are a neurologist, a good neurologist, but, many physicians in small places are doing because of this study, because of this no thrombosis, this thing. And we are very happy to see that, because how many neurologists can't do everything? It's not possible. So I think this is a very good message. Okay, quickly, just take your second case, Pramod, quickly. It seems interesting.
Yeah, just I will show the images actually. So this
just tell the history fast.
Yeah, this was the 22-year-old female with no history of any, nothing was there. GCS was 3 with decerebrate posturing on admission with 5 years of onset of stroke. Pupils were normal size reacting, and she was having small PCA infarct on the left side. There was little very small left PCA infarct. And on the MRI, this also came with after the MRI. And on day 2 MRI brain, she was thrombolized with tenecteplase, and day 2 MRI, she was showing this kind of bilateral occipital infarct, but she became conscious totally. She was following verbal command, everything. And this was her angio. She was completely recanalized basilar artery was there.
What is the first angio? What is the first angio?
No, there was no angio done. It was just screening done on the day of admission.
Okay. So we don't know.
And this was the just last video when she was walking on the discharge.
Yeah, but she's got occipital infarcts.
Yeah. But she was responding to that also, because I think basilar artery.
Yeah, she was GCS3, you said, no?
Yes.
No, that's wonderful here. That means her brainstem was ischemic, and now she's left with top of basilar syndrome.
Yes, sir. Yes.
Probably top of basilar. Is she able to open her eyes?
Yes, sir. Yes.
Because here the eyes are closed.
No, she's just walking with little bit.
No, because top of basilar, your midbrain will go, no?
No, there was no brainstem changes in this MRI. Only the occipital areas were involved.
Okay. So just show that MR angio again. Yeah, how about the PCAs?
These are fine, sir. Both side PCAs. Both are fine.
Both have opened up.
Yeah.
You said she was on OC pills or she was not on OC pills?
Oh, nothing, no history was there. She was just 22 years. We don't know what is the cause and all these things. Echo, cardiac, carotid Doppler, everything was normal.
What about homocysteine and hemoglobin and all that?
Homocysteine was normal. Her ANA and DSDNA was awaited. She was sent on this ANA, DSDNA, everything, vasculitis or something like that. But I didn't think it is something like that, atherosclerotic or something like that. This is some embolic stroke.
No, it's not likely to be atherosclerosis.
Embolic stroke, but where is the source? We don't know in this case.
Okay. So shall we go on to the next person?
T also should have been done in this transesophageal.
Yes, ma'am.
Yes.
Okay, thank you, Pramod. Thank you. Dr. Ashma?
Okay, sir. Mm. Good evening, sir. Madam.
Good evening.
Good evening.
Good evening. Go ahead.
Yes, ma'am. Go ahead.
Okay, so this is a 60-year-old male who is not a diabetic, not a hypertensive. He presented with slurring of speech that was since 2 days, and weakness of the right upper limb since 2 days. So he was out of window period, and on top of that, he had a recent stroke also. That is, he had a recent upper limb.
No, he came within how much time?
2 days, sir. 2 days.
Oh, for 2 days.
Actually, he had a previous stroke within 1 month back. That time also, he had come actually just out of window period. But that time, since he was having vision issues and right upper limb monoparesis, that time actually MR angiogram was done, and he had a frontoparietal infarct. And later a DSA was done, which showed a left ICA dissection, which was 1 month back. And along with this, he also had a seizure disorder for which he is on Eptoin. And along with that, now he also had complaint of slurring of speech, imbalance, and worsening of the pre-existing weakness in the right upper limb, and a reduced response for 2 days. On examination, is moderately built and nourished. No pallor, icterus, cyanosis, clubbing, dependent edema, or generalized lymphadenopathy. Vitals were stable. He was conscious but confused. He was not fully oriented, and attention was impaired. Otherwise, comprehension was normal, speech was normal, fluency, repetition was normal, cranial nerve examination was normal. Tone was normal in all the 4 limbs. Power was grade 4 in right upper limb, proximal and distal, while left upper limb and the lower limbs were 5 out of 5. Deep tendon reflexes were brisk. Plantar was flexor. While cerebellar examination, he had a finger nose test was impaired, and dysdiadochokinesia was present, and rebound phenomenon was impaired. And gait ataxia was also present, so tandem walking was impaired. Since he had a previous history of stroke, we were initially thought of stroke, and initially we took an MRI. But in the MRI, we did not get any acute infarct or bleed. And there was only gliotic changes in the left frontoparietal region and scattered T2 flare hyperintense foci in the bilateral frontoparietal white matter and ventricular system, and extraventricular series of space appeared minimally dilated. So actually in this case, we didn't have any acute infarct or bleed. So we were wondering what was the cause, and we were bound to think in the form of whether it is any encephalopathy. And we checked for the other parameters like sodium, potassium, electrolytes, they were within normal limits. The LFT was normal. Renal parameters were also within normal limit. He had a mild anemia. And then we did a thyroid study which showed that T3 was elevated with 206, while TSH was 0.8 and T4 was 10.4. And in view of this acute ataxia and this decreased response, we thought of this possibility of metabolic encephalopathy, and we sent this anti-TPO, which was 1300, and USC thyroid was showed a mildly heterogeneous thyroid gland with increased vascularity, which was suggestive of a thyroiditis. So Hashimoto encephalopathy was considered, and he was started on steroids. And his condition improved on day 2 of IV methylprednisolone. Ataxia improved and he was able to ambulate with minimal support. Actually, the point I wanted to say this was a case of Hashimoto encephalopathy. Actually, he was referred to our center as a case of recurrent stroke. And he had initially came with a CT. We did an MRI later. We showed there was no acute infarct. So we had this previous stroke was diagnosed as a new infarct, and he was sent to our center. And we treated him with methylprednisolone, and he is now on follow-up, and he is better. After that, DSA was performed again in view of the previous stroke. And in that, we found out he had an ICA dissection because of the previous stroke. Okay, thank you, sir.
Yes, Dr. Sarse.
I think it was a miming of stroke, and that's how he was referred to a neurologist.
Yes, sir.
Basically, he did not have anything on the imaging. So
No, sir.
it was the old stroke which made them go to the neurologist. But I think it was managed properly. But this actually would not come into our discussion for the day to day. So I would not like to discuss further on this.
Okay, sir.
Thank you.
No, Dr. Rashma, first of all, this Hashimoto's encephalopathy is a very vague entity.
Okay, sir.
And not many people accept it as a condition.
Okay, sir.
And, even if TPO antibodies are high and thyroglobulin is high, that doesn't mean that it is the Hashimoto's. First of all, it's a vague entity. And probably he has hyperthyroidism because his T3 is high. And he had a previous stroke, and there could be worsening because of some metabolic insult of the previous stroke.
Yes, sir, definitely.
So, I would not accept Hashimoto's encephalopathy as a diagnosis in this case. Vijaya?
Little, I agree, sir. So, little bit not able to connect the things. So maybe we can, taking this case, we can discuss about this anticoagulants versus antiplatelets in dissection. This is a point where we can do. This I have been discussing with Sailaja, and we are doing one study also. I think you also must be part of that Sailaja study in CAD. I mean, this ICA dissection. So previously, I used to think at least that anticoagulation is a must in these patients for at least 3-4 weeks. But now they say antiplatelets are equally effective and safer than anticoagulation in ICA dissection. What is your take on that, sir?
Yes, I think so. I mean, no study has shown that anticoagulation is better. The dual antiplatelet or even single antiplatelet is as good. And unless, the vessel is totally blocked,
yes,
and there's that rat tail appearance, and therefore you may have to stent it acutely. In that case, we may have to do intervention. This is for extracranial dissection.
Right.
Intracranial dissection, definitely anticoagulation is contraindicated.
Right, sir.
because it may
Exactly.
produce hemorrhage.
More as a
So
SAH
for
and
extracranial, I think both are equal as far as all the studies go, and there's no particular advantage in giving anticoagulation.
yes.
And antiplatelets we would give for about 3 to 6 months. Once they heal, you don't have to give it lifelong.
Right, sir. So actually what I did was, sorry to interrupt you.
Yeah.
So actually acute thing is almost complete occlusion of the ECA. Extracranial ICA is what we are worried. So intracranial, as you said, it is very clear. DAPT for 21 days and go for a single antiplatelet for 3 to 6 months. Underlying etiology you can probe. For extracranial ICA dissection, especially when it is completely occluded and there is a fresh thing that is going on, maybe I thought I gave heparin drip for 3 days and then shifted over to the DAPT once the patient is stabilized. That is what I did. So there, as you said, there are no actual guidelines.
No,
so depending on the ECA, we are worried. There is an acute thing going on. He was having recurrent TIAs. That is the patient where I anticoagulated temporarily. Then went on to the, when discharged on antiplatelets. Just to tide over the crisis.
Yes, yes, I think that is fair. That is fair.
Yes, sir.
In such cases, sir, how long do we anticoagulate if we come across certain cases?
Actually, first week is the highest risk of progression or recurrent stroke, according to me.
Do they require long-term anticoagulants?
No.
Only antiplatelet should be.
Even antiplatelet you require only for up to 6 months. You don't need lifelong because it is not atherosclerotic, and that dissection heals within 6 months. So you don't need the antiplatelets also for more than 6 months. You just stop it. But you have to be very sure that it is dissection. Huh? You know, sometimes it's very tricky to diagnose dissection, even on DSA or fat suppressed MRI pictures. So you have to be very sure that it is dissection and not something else. And then you follow up the patient. You can do a Doppler and see whether the dissection has healed. And if it has healed, I think there's no need to give long-term anticoagulation. But in Rashma's case, I think initially there was a stroke because of dissection. And now because of the metabolic disturbance like thyroid, there was pseudo worsening of the stroke. Because Hashimoto's initially was described when the patient became unconscious or became encephalopathic. Here the patient was not encephalopathic. He had cerebellar signs, maybe the pseudocerebellar signs. Maybe metabolic disturbance can also worsen old stroke. I think this is very important. Any metabolic disturbance, urea goes up, creatinine goes up, electrolyte imbalance, the infection. Now this thyroid, for instance, first time I've seen thyroid worsening a stroke. But yes, I suppose it can produce it. So any metabolic, so if the brain is damaged, then any further metabolic insult can produce what you think is a stroke, but it is not a stroke.
So will that happen even after one? Will that happen even after 1 month?
Yeah, it can happen. Yes. See, because cerebral blood flow is impaired for up to 3 months after a stroke. So, you know, there are areas of luxury perfusion. There are areas of this thing. So the brain is very vulnerable during that period. So any metabolic disturbance occurs during that period can worsen the person. So this is called deteriorating stroke. The causes of deteriorating stroke are outside the central nervous system. They are peripheral. Progressive stroke is when it occurs in the first 7-8 days, it is intracranial cause. But when the situation occurs after a month or after 15 days, the cause is extracranial. Extracranial cause producing pseudo deterioration of the stroke. So you think it is a stroke, but actually it is because of external factors. So this is very important. You know, many patients, just now we've got one patient, you know, she got septicemia due to urinary tract infection. She had a catheter and she has really worsened because previously she had a stroke on, when was it? 26th of January. So about 3 weeks ago. 3 weeks ago, she had a stroke, but because she became septic, she has become unconscious and worsened now. But that is called deteriorating stroke, or there's another word for it, deteriorating stroke, or this thing. But the cause is extracranial. So I think Rashma's case is, the cause is extracranial, but it looks intracranial because the brain is already, impaired. And especially in older people, this thing happens. In younger people, cerebral reserve is good, cerebral blood flow is good, cognitive reserve is good. When cognitive reserve is poor, any small little thing happens, infection happens, hypoglycemia happens, and they really go down. So you must look at extracranial causes very, very aggressively.
Yeah, thanks for highlighting that, sir.
Very
I had absolutely no
clarity.
explanation.
Yeah.
Very, very correct. Very true, sir. Each and every
because,
word.
many times we feel,
Yes,
the scan
UTIs
does not show anything. How is the patient? But you look outside the brain. I think this point is important.
Very important, especially UTIs. I agree with you.
UTI,
In fact,
lung infection.
Yes.
UTI is the worst.
Yes.
It is the worst because catheter is there. Catheter is not cleaned properly. Patient is bedridden.
So much so, when there's deterioration, these days we do CT-KUB. When there is an unexplained neurological deterioration in a patient, we do CT-KUB. Oh, by check karo, urosepsis hai ki nahi.
Yeah.
So
exactly,
this is very, very well brought out this point, sir. I think very practice point. Thank you.
Okay.
Let
Dr.
us go to
Drishti,
the third one.
do we, any further, is Prasanna there? Prasanna, are you there?
Where is the Dr. Prasanna?
He is very quiet, so I don't know he's there or not there. I think he's busy with some other work. Okay. Dr. Drishti, can you continue, please, with your third case?
Yes, sir. Good evening, sir. Good evening, ma'am.
Good evening.
Good evening. So many patients, we stent them. DJ stenting in the hospital, post-stroke.
Huh?
DJ stenting. DJ stenting for
DJ
stenting. Very common these days. Now for us. We do that.
Actually, I'm unable to share my screen, but I think the event people have the.
Yeah, I'll share your screen, ma'am. Just a minute. Please let me know if my screen is visible. Is my screen visible?
Not yet. Not yet. We have a physician's program in Jammu, sir, on Saturday. Ichaporia, sir.
Is it visible now?
Yes, yes.
Yes.
Yes, ma'am, you can go ahead.
Hello, everyone. I'm Dr. Drishti. Can we move on to the next slide? Yeah. So here, it's very simple cases here. There are two cases. First case, he is a 78-year-old man who came to us.
Little loudly, Drishti. Loudly, please.
Okay. Is it better now, sir?
Yeah, speak up. Speak up.
Yeah. So the first case is a 78-year-old male who came to us with facial asymmetry with left upper limb and lower limb weakness. So he woke up at 6 a.m. on 10th of December, and that he felt that he was feeling heavy on the left side of his face with drooling of saliva, but he kept on doing his routine activity. After an hour, a relative came and noticed that there was some facial asymmetry. Around 8 a.m., he started noticing that he was needing support to walk. So they consulted us at 9 a.m. on a video call since they were not sure what's going on. So we noticed that there was a left UMN facial palsy with left upper limb drift. So we told them to rush to the hospital urgently. They were from a very educated family, but then they reached the hospital around 10:30 a.m. Between that, he had started developing left upper limb weakness and he was not able to walk without support. Next slide, please. Yeah, he was a known case of diabetes, but he was not taking his medications, because of which he had developed diabetic neuropathy and bilateral foot drop. And he already had a high steppage gait, but he was managing all his activities independently. Next. So he arrived at around 10:20. Since it was a wake-up stroke which was gradually progressing, we took him for an MRI angio. All his vital parameters were okay, only the BP was 200 by 110. He was a newly detected hypertensive also, so we were not sure whether this is a bleed or a stroke. The ECG had first degree AV block. Next slide. When he came, his NIHS was around 9. He had a facial asymmetry. There was a left upper limb, lower limb weakness with limb ataxia and mild dysarthria. Next. This was his MRI. The diffusion was showing a right gangliocapsular infarct, which was hyperacute. He had a lot of white matter hyperintensities, but this specific one was not developed. He had microbleeds as well, but there were a few microbleeds only. Though it was a very small lacunar infarct, probably happening because of a cerebral small vessel disease, but it was a disabling stroke with an NIHS of 9, though coming after 4.5 hours, but it was a wake up stroke. Next slide. Next. Angio was normal. Next. So we thrombolized him in view of diffusion flare mismatch. Next slide. His 2D echo was normal and the etiology was considered as small vessel disease. Next slide. His NIHS post 1 hour of thrombolysis had reduced to 4. Next slide. 24 hours post thrombolysis, the NIHS was 1. Mainly the left lower limb, which already had a pre-existent foot drop, was hypotonic a little bit. So he was needing support of a walker for walking. Next slide. He was discharged on a walker support on day 4, but after a month he came to the hospital driving his own car, with able to walk independently back into action. It was a very...
Wait. What is the message you want to give, Drishti?
That we need to look into our comorbidities well. Other thing is that we should reach the hospital on time and recognize our symptoms very well. The other thing is that, sir, he had a lot of microbleeds in his SWI, which...
No, there were few. You
Sir,
said
I
they
did
were
not...
less than 10, no?
Yeah, so they were less than 10, so we went. There was a high risk of bleed here, but then we went ahead, explained the relatives well, and...
Did you bring the blood pressure down?
Yes, we did, sir. With labetalol, I got down the blood pressure. There was a catch here that he had first degree AV block, but I needed to be fast, so I did use labetalol. We had slight bradycardia issues for the next 2 days. That is why we had to keep him in the
How much
ICU.
labetalol did you give?
Sir, 10 mg.
Only?
Yeah, it came down with...
Okay, so that won't produce any cardiac disturbance. We don't need to worry about that.
Yes.
In grade 1, the AV block is insignificant.
Yes.
No, what question I want to ask is, in lacunar stroke, is thrombolysis effective?
So if it's a disabling stroke involving a particular area like a capsule, which can cause a more
lacunar
NIHS...
stroke. No, lacunar stroke with significant deficit, is thrombolysis effective?
I would say yes, sir. Though
it is an
it's a debatable
unequivocal
topic.
yes.
Yeah, it's a debatable issue.
No, it's not debatable. It is unequivocal. If there is a neurodeficit, whether it is large vessel, small vessel, medium vessel, lacunar, it does not matter. Lacunar infarcts also improve with IV thrombolysis. So I think you have done very well with this case. Of course, you have to get the blood pressure down. Now, really, was it wake up? Because at 7 o'clock when he got up, There was only facial weakness, no?
So, sir, that is the reason I got an MR done, and I wanted to see whether a diffusion flare mismatch, because I was not really sure what timing I'm dealing with. And there was nobody else with the relative till around 7 o'clock. So I did not know what's happening.
Okay,
So,
no, that's fine. So what you have done is excellently well. So the message that we want to give is that if there is a lacunar infarct also, IV thrombolysis is effective.
yes.
You know, there was a debate some time ago that lacunar infarcts, because it is arteriosclerosis and not atherosclerosis, they do not do well with IVT, but that has been disproved.
Yes.
The lacunar strokes also do well with IVT, and if there is disabling deficit, you should certainly give it.
Yes.
And the very fact that he had microbleeds in the basal ganglia, and this time also his BP was high, it is likely that he had chronic hypertension, because
Yes.
those microbleeds are not like cerebral amyloid angiopathy. They
Yes.
are because of hypertension.
Hypertension.
The hypertensive microbleeds are in the basal ganglia. So this is probably, he was hypertensive, not known or not checked. And if they are less than 10, it is actually, even 10 is not a contraindication. It has to be given with care. I mean, what that means, I don't know, but it's not a contraindication. So if there are 4 or 5, you can safely give it, but you keep the BP down. And I think you have done well for the patient, and he's recovered beautifully. So congratulations to you for giving this treatment. Vijaya?
Yes, sir. So even the original NINDS study, where they included all the strokes back in 1996, the best outcomes were in the lacunar strokes. So it's not, as you said, it is you are adding to the good. It's going to the best. The microbleeds, I agree with you. 10 is the cutoff according to the evidence. It's the guidelines. We can't do anything about it. So at least if you are less than 10, you are very well supported by the guidelines. And disabling, the other point that you have to discuss in this case, sir, what is disabling stroke in a 70-year-old man? That is the thing, left side stroke. Is it really disabling? That's the most important crux of the decision here, I feel. If it is a disabling stroke, you have to thrombolize. If you think it is definitely not disabling stroke, you should not thrombolize. Now there are two separate things. How to decide whether it is disabling or not? One thing they say is the ADL activities. If the patient will be have problem with these ADL activities like bathing or eating or dressing or walking, then it is disabling. If it is only pure sensory or pure just maybe ataxia, maybe we can leave them. But in this case, it is progressing also, and it is looks like a disabling stroke for that, even for that age. This is the one important point this case illustrates.
Yeah, Dr. Sase?
What do you think is the most ideal drug to control hypertension in a very short period of time when you want to thrombolize? That question we always come across when we want to reduce the blood pressure in a shorter period of time, because that is likely to bring down the proximal pressure head and worsen the ischemia if you suddenly bring down the blood pressure.
No, but if you are going to thrombolize, you have to bring the blood pressure down to below 180 by 105.
Yes.
And the drug that we use routinely is labetalol. If
Yes.
you're not thrombolizing, then you don't need to bring down the BP rapidly. Then you give oral drugs.
No, I was asking in the situation.
Bring up the BP by 15% per day, gradually over 7 days. Even in the first 7 days, you need not bring it down. So you give oral drugs, which will act in 2-3 days. Gradually, the BP will come down. But if you're thrombolizing, you have to have the BP below 180 by 105 and keep it there. So just one dose of labetalol may not be enough. You may have to start a labetalol drip, or
Infusion,
you may have to give recurrent boluses of labetalol. Either way. But it's a very, very safe drug. It can be used even if there is cardiac failure. It can be used even if there is aortic dissection. It can be used even if there is asthma. because it is a selective beta blocker.
Beta blocker.
It does not act on the respiratory system, and it's very safe. And we have used it extensively, even up to 250 milligrams. Vijaya, what is your view on
Yes,
labetalol?
Even our favorite drug is labetalol.
Yeah.
And they say this one, clevidipine and all, but it's not available in India.
Correct.
I see it in US. The second one is we have nitroglycerin when the patient is very high and not coming down with this thing. And the patient is a cardiac patient also. Those patients only were using nitroglycerin.
Correct. So
Otherwise,
nitroglycerin for cardiac patients, preferably not for CNS patients, because it dilates the vessels in the brain.
Correct.
And it can produce luxury perfusion. Second drug that we use sometimes when labetalol, very rarely, is enalapril.
Enalapril, yes.
IV. But very rarely we use it.
We
Maybe
need to
a
use
year once or twice. But labetalol is superb drug. And it can be titrated. You can go up and down. And even for intracerebral hemorrhage, it's an excellent drug to use. So don't be scared of one first-degree heart block, and nothing's going to happen. And anyway, it's short acting. Within 5 minutes, the effect will go away. So if you find that the heart is becoming slow, or junctional rhythm is coming, or second degree, just stop the drug. Within 5 minutes, it will reverse. So don't worry about it, Drishti.
Yes, yes. Sir, so I just had a question. If, say, suppose he had a junctional rhythm and his heart rate was, say, around 40. So in such
Then
a
maybe
case,
you would use enalapril.
Yeah.
Maybe enalapril.
So with this patient, what had happened was that for the next 2 days, he was kept in the ICU only because he had bradycardia. His
How
heart
much?
rate was dropping up till 28.
You can give RC best or Delphilin.
Yeah, you can give RC best. Yeah.
Yes, we
So
started
he may
that.
be having sick sinus syndrome or something.
Usually asymptomatic. They revert.
Yeah, he may be having sick sinus, first degree heart block going on to junctional rhythm. So it's like a sick sinus. But what message I think that all of us want to give y'all is labetalol is a safe drug. It's highly effective, it's short acting, and it works wonders. Of course, there are exceptional cases now. If there's severe bradycardia, of course, we would not give it. But those are very rare. In a year, maybe 1 or 2 cases may come like that. But vast majority, it is a very safe and effective drug. So use it. Don't use this sublingual nifedipine and all that nonsense, because then you can't control the BP, and it crashes to 60, and then you put a noradrenaline drip, and oh God, there's a mess. It's an absolute mess. So use labetalol, and it works superbly. I think we are running out of time. Rishi, do you have a case? Short case, 5 minutes.
Yes, sir. But I mean, it's similar to actually the first case in which there was a basilar artery thrombosis and it was thrombolized, and the next day patient was normal. So I think the message is pretty much
great.
there.
So message is, even in basilar artery thrombosis, give IVT. Don't only think of EVT. Give IVT. You'll be surprised how many times it opens up. Of course, EVT should be done if it doesn't open, but give it. Okay, Kalpita, can we wind up?
Yes, sir. I think it was a very interesting session, and especially we touched upon the recent trial also that came up. So I think it was a very fantastic session, and I would like to thank each and every one of you, Dr. Vijaya, Dr. Richa Poria, all the moderators, all the speakers. It was definitely a great learning session for all of us, and even I have made certain notes which we can further integrate in our stroke awareness communication. So thank you so much once again.
Yes. How many attendees?
Sir, for the registrations currently we have 131, and the logins are still updating because it is real time. 131 there are actual registrations.
Okay. At least 131 people could have benefited.
Yes, sir.
So every time, as you said, each time we learn something more, and the resolve to give IV thrombolysis is increasing every time we speak on this platform.
So
It
Indian
gives
Stroke
more
Association
confidence.
has done, Vijay is the president of Indian Stroke Association, and one of the objectives is to improve stroke care across the country. And I think slowly and steadily we are doing it.
Yes, sir. I'm taking it to Jammu day after tomorrow.
Okay. Yeah. So,
Jammu.
across the length and breadth of the country,
Yes, yes.
it is happening.
Yes.
We
That's
want
very-
it to happen faster,
Right.
but it's still happening.
Yes.
So I think, and this is one session where physicians are coming, physicians are talking, and I think it's a very, very good initiative of Gennova. So thank you, everyone, and
Thank you so much.
good evening.
Kalpita, see you in Jammu on Saturday.
Okay.
Sure, ma'am. Thank you so much.
Good night.
Thank you, Dr.
Thank you,
Ichapuria.
everyone.
I wanted to leave in 10 minutes because of your thing. I stayed to learn from you.
Are, I learn from you. I've been learning from you for last 30 years.
It's a mutual thing. Thank you,
Okay.
everyone.
Thank you.
Thank you.
Bye.
Thank you so much, everyone. Thank you.
Bye. Bye.